Hello and welcome. Do you want to successfully complete the D033 OA exam? Then you are in the right place. Our website has free questions and answers for the D033 OA exam. We know OA exams are tough, so our guides and practice questions are all free. With over 100 plus success stories, we have proven our videos will help you pass your exam on the first attempt. In this video, we will cover questions from federal regulations, interoperability standards, clinical informatics, systems development, system procurement. So, let's get started.
Question 1. A hospital compliance officer is preparing training for new billing staff on federal regulations that govern healthcare transactions. The officer wants to emphasize the federal law whose Title II specifically targets fraud, abuse, and administrative simplification in healthcare business processes. Which law should be the centerpiece of the training? Your options are A. The Affordable Care Act of 2010, B. The Health Insurance Portability and Accountability Act of 1996, C. The Emergency Medical Treatment and Active Labor Act, D. The Patient Safety and Quality Improvement Act of 2005. Which one is it? Pause the video if you need more time. The correct answer is B. The Health Insurance Portability and Accountability Act of 1996. B is correct because HIPAA Title II covers administrative simplification, healthcare fraud and abuse prevention, and standards for electronic transactions. It is the federal law most directly aimed at streamlining and protecting healthcare business processes. A is wrong because the Affordable Care Act focuses on expanding insurance coverage and reforming payment models, not on administrative transaction standards or fraud prevention at the transaction level. C is wrong because EMTALA requires hospitals to provide emergency screening and stabilization regardless of ability to pay. It has nothing to do with billing administration or electronic transaction standards. D is wrong because the Patient Safety and Quality Improvement Act created patient safety organizations for confidential reporting of medical errors. It does not address healthcare billing or administrative simplification. HIPAA was passed in 1996 to bring order to a healthcare system going electronic. While the law has 5 titles, it's Title II, Administrative Simplification, that health information professionals encounter every single day. Title II groups 3 major reforms together. It tackled rampant healthcare fraud with dedicated federal definitions and stiffer penalties, mandated standard formats for electronic claims and related transactions, and established the privacy and security protections that govern health data today. HIPAA contains 5 titles, but they serve very different purposes. Title I protects insurance coverage when workers change jobs. Title II is the administrative engine, covering fraud, billing standards, and privacy rules. Titles 3 through 5 handle tax provisions, group plans, and revenue offsets respectively. 3 laws are commonly mixed up on exams. HIPAA created administrative simplification. The Affordable Care Act expanded insurance coverage and payment reform, but did not redefine Title II. HITECH extended HIPAA enforcement and incentivized EHR adoption, but did not invent the standards. Those came from Title II. When an exam stem mentions transaction standards, electronic code sets, or healthcare fraud prevention, your anchor is always Title II. Keep its 3 core goals clear, and you can distinguish it from every other title and every related law that followed. Question 2. A health information manager is reviewing which organizations in her region must comply directly with HIPAA requirements as covered entities. She needs to identify the group that is correctly classified. Which organization is a covered entity under HIPAA? Your options are A software company that markets health apps directly to consumers, B, a private fitness club that collects body mass index readings from members, C, a non-profit foundation that funds cancer research grants, D. A health plan that reimburses hospitals for inpatient claims. Take a second. Which answer would you pick? The correct answer is D. A health plan that reimburses hospitals for inpatient claims. D is correct because HIPAA defines covered entities as health plans, healthcare clearinghouses, and healthcare providers that transmit health information electronically for covered transactions. A reimbursing health plan fits squarely in this definition. A is wrong because consumer health apps fall outside HIPAA unless the vendor acts on behalf of a covered entity or has a business associate agreement. Marketing directly to consumers does not create covered entity status. B is wrong because fitness clubs are not healthcare providers and do not conduct covered transactions. The BMI data they collect sits outside HIPAA jurisdiction. C is wrong because a research foundation that only funds grants is not a provider, plan, or clearinghouse. Funding research is not a HIPAA-covered activity. HIPAA doesn't apply to every organization that touches health data. It targets a precisely defined group called covered entities, organized into 3 categories established by law. Health plans pay for care. Think insurers, HMOs, and Medicare. Clearinghouses are the middlemen translating claims between formats. Providers are the broadest group, but critically, only those who transmit health information electronically through covered transactions actually qualify. The electronic transaction trigger is the most misunderstood part of the provider definition. A cash-only clinic handling clinical records is outside HIPAA. The moment that same clinic starts submitting electronic claims, it crosses the threshold and becomes fully subject to the privacy and security rules. Business associates sit just outside the covered entity definition. They handle protected health information on behalf of covered entities and are bound by many of the same requirements through signed agreements and direct liability rules introduced by HITECH. The covered entity framework exists to give HIPAA a finite enforceable target. Fitness apps, research foundations, and cash-only clinics that skip electronic transactions generally fall outside it. Keeping these boundaries precise prevents both overclaiming HIPAA's reach and missing genuine obligations on the covered side. Question 3. A patient requests a copy of her medical record and asks which federal privacy provision gives her that right. The hospital's privacy officer wants to answer with the correct rule. Which HIPAA provision gives her the right to access her own protected health information? Your options are A. The HIPAA privacy rule, which establishes patient rights over protected health information. B. The HIPAA security rule, which focuses on electronic safeguards for data. C. The HITECH Act audit log rule, which covers only breach notifications. D. The ARA meaningful use rule, which governs EHR incentive payments. Before I reveal it, which one do you think is right? The correct answer is A. The HIPAA privacy rule, which establishes patient rights over protected health information. A is correct because the HIPAA privacy rule established patient rights, including the right to access, amend, and request an accounting of disclosures of protected health information. It is the foundation of patient information rights under federal law. B is wrong because the security rule addresses administrative, physical, and technical safeguards for electronic PHI. It supports privacy but does not define patient access rights. C is wrong because HITECH expanded breach notification and enforcement. Patient access rights were already established under the privacy rule before HITECH. D is wrong because meaningful use drove EHR adoption through incentive payments tied to specific quality measures. It does not grant patients rights to their records. The HIPAA privacy rule is the federal standard that defines what patients can expect from any organization holding their health information. It took effect in 2003 and did something genuinely new. It gave patients enforceable rights over their own records. replacing a patchwork of inconsistent state practices. The rule enumerates 5 key rights. Patients can view and copy their records, request corrections, learn who received their information outside of routine care, ask for limits on use, and receive a plain language privacy notice from every covered entity. Both rules live inside HIPAA Title II, but they solve different problems. The privacy rule governs what information can be shared and with whom in any format. The security rule governs how electronic records are technically protected. Mixing them up is the most common exam mistake. The privacy rule's minimum necessary principle requires covered entities to limit information use to what the purpose actually requires. Clinicians treating a patient get broader access. Billing and operations face tighter limits. Disclosures outside those 3 categories generally require the patient's written authorization. When an exam stem describes a patient exercising a right over her own information, access, amendment, or accounting of disclosures, the answer centers on the privacy rule, not the security rule and not high tech. Purpose defines the rule. Mechanism is a separate question entirely. Question 4. A billing clerk at a clinic notices that several paper claim forms contain patient name, date of birth, address, and diagnosis codes. The clerk is asked to categorize this data correctly for a privacy training exercise. How should this information be classified? Your options are A. De-identified health data because diagnosis codes alone are numeric. B. Aggregate research data because the claims form serves statistical purposes. C. Protected health information because it combines individually identifiable data with health details. D. Business operations data because billing is a financial function. What's your answer? Commit to one before I continue. The correct answer is C. Protected health information because it combines individually identifiable data with health details. C is correct because protected health information includes any individually identifiable health information held or transmitted by a covered entity. Names, dates, addresses, and diagnosis codes together clearly identify individuals and their conditions. A is wrong because de-identified data has had all 18 HIPAA identifiers removed or altered through safe harbor or expert determination. A claim form with name and address has not been de-identified. B is wrong because aggregate data refers to summary statistics that cannot be linked to individuals. Raw claim forms with patient details do not meet that bar. D is wrong because business operations is a permitted use category under HIPAA, but the data itself remains PHI. Classifying by use purpose does not remove the information from PHI status. Protected health information is a precise legal category that HIPAA uses as its trigger. Understanding exactly what qualifies is the foundation of every privacy and security obligation under the law. The definition has 2 parts that must both be true simultaneously. The record must relate to health, physical, mental, past, present, future, care provided, or payment, and it must identify or reasonably could identify the individual. Either element alone is not enough. The critical insight is that PHI lives in the combination. A diagnosis code is health data but not usually identifiable. A name and address are identifiable but carry no health content. The moment they appear together on the same record, the aggregate is unmistakably PHI. Organizations can step outside HIPAA's reach through de-identification. Safe harbor removes all 18 named identifiers. Expert determination uses statistical methods to confirm a identification risk is very small. Either path produces data that is no longer PHI, which is why researchers often request de-identified extracts. The most common mistake is thinking that operational use, research labels, or internal routing somehow changes a record's status. They don't. Whether a record is PHI depends entirely on what it contains, not what it's called or where it's going. Question 5. A new health information security officer is tasked with the required first step before implementing electronic safeguards under the HIPAA security rule. The officer needs to understand what threatens the organization's electronic protected health information before choosing controls. Which activity meets this requirement? Your options are A. Installing antivirus software across all workstations and servers. B. Conducting a formal risk analysis of threats, vulnerabilities, and potential impact. C. Training staff on password management and email phishing awareness. D. Signing business associate agreements with all third-party vendors. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is B. Conducting a formal risk analysis of threats, vulnerabilities, and potential impact. B is correct because the security rule requires covered entities to conduct a risk analysis as the foundation for selecting administrative, physical, and technical safeguards. Without identifying threats and vulnerabilities first, control selection would be guesswork. A is wrong because antivirus deployment is one technical safeguard, but it comes after analysis reveals where malware poses a risk. Jumping to controls bypasses the required analytical step. C is wrong because training is required, but it is a downstream control chosen based on identified risks. It is not the foundational first step. D is wrong because business associate agreements are separate contractual requirements. They do not replace the internal risk analysis of the organization's own systems. The HIPAA security rule governs how covered entities protect electronic protected health information. At its core is a foundational requirement that organizations understand their own risk environment before selecting any controls. The security rule organizes its requirements into three categories: administrative, physical, and technical safeguards. Risk analysis sits in the administrative category and must come first. It drives every decision that follows. The process starts by cataloging every system that creates, stores, or transmits EPHR. From there, the organization identifies threats, potential causes of harm, and vulnerabilities, weaknesses that could be exploited, then estimates likelihood and impact to produce a prioritized risk rating for each combination. Two exam traps appear repeatedly. First, risk analysis is not a one-time event. Significant changes in technology or operations require a fresh assessment. Second, specific controls like antivirus or password training are downstream choices. They cannot replace the analysis that should have selected them. When an exam stem asks what comes before safeguard selection, the answer is always the formal, documented risk analysis. Regulators asked after an incident will want to know exactly when the last one was completed. Question 6. A regional hospital network wants to allow emergency department clinicians to view recent laboratory results and medication lists from nearby clinics that use different electronic record systems. Which capability is the network trying to establish? Your options are A. Health information exchange, which allows sharing of clinical data across organizations. B. A master patient index, which assigns unique identifiers within a single facility. C. A charge master, which organizes billable item for hospital revenue capture. D. A clinical pathway which standardizes treatment steps for specific conditions. Which would you go with? Lock it in before the reveal. The correct answer is A. Health information exchange, which allows sharing of clinical data across organizations. A is correct because health information exchange is the electronic movement of clinical data among different healthcare organizations so that clinicians at the point of care can see a fuller picture. Cross-organization lab and medication sharing is the textbook HIE scenario. B is wrong because a master patient index identifies patients within a single organization's systems. It does not move data between organizations. C is wrong because a charge master lists items and prices for billing. It has no role in clinical data sharing. D is wrong because a clinical pathway is a care protocol. Protocols are not the mechanism for sharing records between facilities. Health Information Exchange, or HIE, is the electronic movement of clinical data between separate healthcare organizations. It exists because the US healthcare system is deeply fragmented, and that fragmentation creates real clinical risk. A single patient may visit a primary care doctor, a specialist, a lab, and a pharmacy, all under different organizations. Without HIE, each encounter is isolated. Clinicians repeat tests, miss drug interactions, and prescribe conflicting treatments. HIE can be built three ways. A centralized model pulls data into one shared repository. A federated model leaves data at the source and queries it on demand. A hybrid model uses a central index to route queries to the right source. Same goal, different architecture. When HIE works, emergency clinicians see prior encounters for unconscious patients. Discharge summaries flow automatically to nursing facilities, and public health agencies can track conditions across an entire region. The most important exam concept, HIE specifically means data moving between legally separate organizations. An EHR connecting a hospital's own lab and pharmacy is internal interoperability, not HIE. Different governance, different consent requirements, different technical challenges entirely. Question 7. A health informatics team is mapping the 4 levels of interoperability to prioritize their roadmap. Management wants to know which level is considered the most difficult to achieve because it requires shared meaning across systems, not just exchange of bits and syntax. Which level is being described? Your options are A. Foundational interoperability, B. Structural interoperability, C. Semantic interoperability, D. Organizational interoperability. Don't overthink it. Which one feels right? The correct answer is C. Semantic interoperability. C is correct because semantic interoperability requires systems to interpret shared data using common definitions and vocabularies such as SNO-END CT or LOINC. It is cited as the most technically difficult level because encoding meaning consistently across vendors and institutions takes agreement beyond transport and format. A is wrong because foundational interoperability is the simplest level. One system can send data to another, but the receiver does not need to interpret it. B is wrong because structural interoperability defines the format and syntax of exchange data, so fields land in the right places. Structure is necessary but insufficient for shared meaning. D is wrong because organizational interoperability layers policy, governance, and workflow on top of semantic agreement. It is the newest level, but semantic is what the 4-level model flags as the hardest technical layer to actually achieve. Interoperability is the ability of different health information systems to exchange and use data. HIMSS and ONC define 4 distinct levels, each building on the one below it, and each harder to achieve than the last. At the foundational level, bytes travel from one system to another. Data arrives intact but carries no automatic meaning. Structural interoperability adds field mapping, so a lab result lands in the right place in the right chart. Semantic interoperability goes further. Both systems share the same definitions, so a diagnosis means the same thing on both ends without manual reconciliation. Semantic interoperability is consistently cited as the hardest technical layer because it demands coordinated vocabulary work across competing vendors and institutions. Foundational and structural problems are largely solved in modern deployments. Semantic requires ongoing agreement on what data actually means. On exam stems, watch for words like shared meaning, common vocabulary or most difficult level. When the question emphasizes meaning rather than transport or field placement, semantic interoperability is your target answer. Question 8. A state-level HIE consortium is debating architecture options. One proposal keeps patient records at each participating hospital and queries them only when a clinician makes a request, with no central repository of clinical data. Which HIE architecture does this describe? Your options are A. Centralized, where all data resides in a single regional repository. B. Hybrid federated, where a central index points to distributed data stores. C. Cloud tethered, where data is synchronized to a shared vendor platform. D. Decentralized, where data remains at each source and is queried on demand. Got a guess? Lock it in. The correct answer is D. Decentralized, where data remains at each source and is queried on demand. D is correct because A. Decentralized architecture leaves records at the source systems and pulls them only when a query arrives. No master repository of clinical data exists. This matches the proposal exactly. A is wrong because a centralized HIE holds all clinical data in one repository. The proposal explicitly avoids a central repository, so centralized does not apply. B is wrong because a hybrid federated model keeps data distributed but uses a centralized index or record locator service to find where records live. The proposal did not mention any central index component. C is wrong because cloud tethered is not one of the recognized HIE architecture categories. It is a distractor, not a real option in the 3-model taxonomy. Health information exchanges are built on one of 3 core architectures, each making different trade-offs in how patient data is stored, owned, and retrieved. Understanding these distinctions is essential for matching exam stems to the right model. Centralized architectures consolidate all clinical data into one shared repository. Decentralized architectures leave data at each source organization and query them on demand. Hybrid federated architectures keep clinical data at sources, but add a central index that tracks where each patient's records live. The key structural difference is the presence or absence of a central layer. Only hybrid federated introduces a middle tier, the record locator service, that indexes patient pointers without ever holding the clinical records themselves. When an exam stem describes a specific design choice, focus on 2 things: where the clinical data lives and whether any central component exists. A record locator service or central index is the signature of hybrid federated chain Wernham. Its presence distinguishes it from a purely decentralized design. The most common error is conflating hybrid federated with decentralized. Both leave clinical data at the source, but hybrid federated always adds a central index layer. If the stem mentions any central component at all, decentralized is off the table. Question 9. A chief medical information officer wants to improve how a hospital's pharmacy, laboratory, and radiology systems feed data into the electronic health record used by clinicians. She is not yet addressing data exchange with outside clinics. What type of interoperability is she focused on? Your options are A. External interoperability between affiliated provider groups. B. Internal interoperability among systems within one organization. C. Semantic-only interoperability that ignores workflow. D. Organizational interoperability driven by federal policy. Which one is it? Pause the video if you need more time. The correct answer is B. Internal interoperability among systems within one organization. B is correct because internal interoperability addresses data flow among systems operated by a single organization. Pharmacy, lab, and radiology feeding the EHR inside one hospital is the classic internal scenario. A is wrong because external interoperability covers data exchange between separate organizations. The CMIO has explicitly not moved to outside clinics yet. C is wrong because semantic only is not a standard category and ignores the structural and organizational pieces required in any real integration project. D is wrong because organizational interoperability sits above internal system integration and addresses governance, policy, and workflow across entities. It is not where she has started. Interoperability in healthcare splits into two distinct levels, some, and understanding where the organizational boundary falls is the key to telling them apart. Internal interoperability connects systems within a single organization, a tool base, pharmacy, lab, radiology, and EHR all sharing data under one roof. External interoperability crosses organizational walls, linking hospitals, clinics, labs, and health information exchanges that have different vendors, different budgets, and no shared authority. Inside one organization, data flows through ADT messages and departmental feeds that a single IT team can govern. Across organizations, the same HL7 HIPAA standards may apply, but governance frameworks like TEFCA and cross-entity patient matching become essential because no single authority controls all parties. On exam stems, ask one question first. Does the scenario stay inside a single organization or cross into another? A CMIO consolidating hospital systems is an internal problem. A hospital sharing records with an outside clinic or a state HIE is an external one. Technology like HL7 messaging appears in both contexts. So the organizational boundary, not the tool, determines the correct label. Question 10. A systems analyst is documenting the messaging standard used to transmit admission, discharge, and transfer messages between a hospital information system and its clinical department applications. The standard has been the dominant messaging framework in healthcare since the late 1980s. Which standard is being described? Your options are A. HL7, which defines messaging formats for clinical and administrative data. B. ICD-10, which standardizes diagnosis and procedure codes. C. CPT, which codes physician professional services for billing. D. LOINC, which names laboratory observations and measurements. Take a second. Which answer would you pick? The correct answer is A. Charles 7, which defines messaging formats for clinical and administrative data. A is correct because Health Level 7 International developed HL7 as the messaging standard for exchanging clinical and administrative data between healthcare applications. ADT messages are one of the most common HL7 message types. B is wrong because ICD-10 is a code set for diseases, injuries, and procedures, not a messaging protocol. Code sets ride inside messages but do not define message structure. C is wrong because CPT codes physician services and procedures for reimbursement. It is a billing terminology, not a messaging standard. D is wrong because LOINC is the standard for naming laboratory tests and clinical observations. It is a vocabulary, not a messaging standard. HL7 is the dominant messaging standard that governs how clinical and administrative data moves between healthcare applications. It defines structure and syntax, not the clinical content itself. Version 2 is the workhorse behind most existing hospital integrations. Version 3 attempted a more rigorous model but saw limited uptake. FHIR is the modern successor, powering new external-facing APIs with web-friendly RESTful design. The critical distinction is that HL7 is the envelope. It defines how messages are structured and exchanged. Code sets like ICD-10 and CPT, and vocabularies like LOINC and SNOMED-CT are the content carried inside those envelopes. ADT messages drive downstream reactions like bed assignment and billing. Order messages move clinical orders between systems. Result messages return finding. For example, A radiology report sent from a RS to the EHR the moment a radiologist finalizes it. When an exam stem mentions message structure, data exchange between clinical systems, or ADT events, HL7 is the answer. It is a family of messaging standards, never a code set, never a single product. Question 11. A hospital wants to reduce medication errors tied to illegible handwriting and incorrect dosages when physicians write orders. Which system directly replaces handwritten orders and provides built-in prompts and alerts at the time of order entry? Your options are A. Electronic medication administration record, B. Automated dispensing cabinet, C. Computerized provider order entry, D. Pharmacy benefit management system. Before I reveal it, which one do you think is right? The correct answer is C. Computerized provider order entry. C is correct because computerized provider order entry replaces handwritten orders with structured electronic entry, built-in drug allergy, drug-drug interaction, and dosing alerts fire at the moment of order, catching errors at the source. A is wrong because the electronic medication administration record documents what was actually given to the patient at the bedside. It sits downstream of the order. B is wrong because automated dispensing cabinets control medication access on the unit. They help once the order is already placed, not during order entry. D is wrong because pharmacy benefit management systems handle drug coverage and claims adjudication on the payer side. They are not order entry systems. Computerized provider order entry, CPUE, is the part of the EHR dedicated specifically to writing orders. It replaces handwritten and verbal orders with structured electronic entry that routes instantly and checks safety in real time. A physician or authorized clinician selects the patient and enters any type of order, so medications, labs, imaging, nursing interventions, or discharge instructions. Every entry lands in the chart immediately and routes automatically to the correct department. The power of CPOE lies in its layered safety checks: dose range checking, drug allergy checking, drug-drug interaction checking, and duplicate therapy checking all fire the instant the order is written, not hours later when a pharmacist reviews it. A critical exam distinction: CPOE handles ordering only. Documentation and progress notes and flow sheets happens elsewhere in the EHR. The EMR records what the nurse actually gave the patient at the bedside. CPOE sits at the very front of that chain. When you see CPOE on an exam, think ordering and safety alerts part to, not documentation, not administration. It addresses the root causes of handwritten prescription errors by structuring the order entry process from the very first keystroke. Question 12. A nurse manager wants to understand the category of computer system that directly supports clinical staff at the point of care with tools for documentation, orders, and results review. Which term best describes this category? Your options are A. Administrative Information System, B. Clinical Information System, C. Executive Information System, D. Decision Support Dashboard. What's your answer? Commit to one before I continue. The correct answer is B. Clinical Information System. B is correct because a clinical information system supports the direct care of patients. It includes documentation, order entry, results review, and clinical decision support tools used by nurses and physicians. A is wrong because administrative information systems support business operations like admissions, billing, and human resources. They do not directly support clinical care. C is wrong because executive information systems give senior leaders summary dashboards and strategic reports. They are a reporting layer above the operational systems. D is wrong because decision support is a feature built into clinical information systems, not a category of system itself. The question is asking for the overall system category. Clinical information systems are a category of software defined by their purpose, directly supporting the care of patients. Understanding the category, not just individual products, is what separates a solid answer from a misread on an exam question. Any system whose users are clinicians and whose outputs feed patient care decisions belongs in this category. The vocabulary it uses matters too. Clinical systems speak in diagnoses and medications, not cost centers or billing codes. Hospitals run three broad categories of software. Clinical information systems sit alongside administrative systems, which handle billing, scheduling, and HR, and executive information systems, which give leaders high-level dashboards. Mapping software by category helps leaders align tools with purpose. The EHR is the most familiar clinical information system, but it is one member of a broader category. Clinical decision support is not its own standalone category. It is a feature that runs inside a clinical information system, most often the EHR. When an exam STEM asks about software used by nurses and physicians at the point of care, think clinical information system. When it asks for the specific application replacing the paper chart, think EHR. Keeping that distinction clear prevents the most common misread on this topic. Question 13. A physician logs an antibiotic order for a patient with documented penicillin allergy, and the EHR immediately displays an alert recommending an alternative. Which system component generated this alert? Your options are A. Master Patient Index, B. Charge Master Lookup, C. Data Warehouse Query, D. Clinical Decision Support. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Clinical Decision Support. D is correct because Clinical Decision Support analyzes order entries against patient data and rules, then delivers prompts, reminders, and alerts at the point of care. Allergy checks on antibiotic orders are a classic CDS use case. A is wrong because the Master Patient Index identifies patients and reconciles duplicates. It does not evaluate orders against allergies. B is wrong because Charge Master lookups map services to billing codes. They are not involved in safety alerts. C is wrong because Data Warehouse Queries run retrospective reports. They do not fire real-time alerts during order entry. Clinical Decision Support is about delivering the right knowledge to the right clinician at the exact moment a decision is being made. Rather than relying on memory alone, the system surfaces relevant information directly inside the clinical workflow. Decision support can take many forms: a drug allergy alert, a pre-built order set for pneumonia, a reminder to screen for depression, or a link to current guidelines. What unites them is that they appear inside the workflow, not in a separate system the clinician must go find. Under the hood, every alert is produced by pairing a rules engine with a knowledge base and real patient data. A drug allergy alert fires only when the current order matches something on that specific patient's allergy list. Generic knowledge becomes actionable because it is checked against the individual. The critical operational trap is alert fatigue. When alerts fire too often or at the wrong moment, clinicians learn to dismiss them without reading. A 95% override rate is a signal that an alert should be redesigned or removed entirely. More alerts is not always better decision support. Remember, a retrospective dashboard or a population report is not clinical decision support. True CDS delivers patient-specific, knowledge-driven prompts precisely when a clinician is about to act. That timeliness is what defines the category. Question 14. A HIM director is explaining to new staff how a document management system differs from an electronic health record. Which statement accurately captures the core difference? Your options are A DMS scans and stores images of documents while an EHR captures structured clinical data. B. A DMS replaces the EHR in hospitals that have moved fully to imaging. C. A DMS is used only by radiology, while an EHR is used only by physicians. D. A DMS is a federal standard, while an EHR is an optional vendor product. Which would you go with? Lock it in before the reveal. The correct answer is A. A DMS scans and stores images of documents, while an EHR captures structured clinical data. A is correct because a document management system digitizes paper documents and stores them as images with metadata. An EHR stores structured, discrete clinical data that can be queried, analyzed, and fed into decision support. B is wrong because DMS and EHR coexist rather than replace each other. A DMS often holds scanned historical or external documents alongside the EHR. C is wrong because both systems are used across departments and by many roles. The distinction is about data format, not user type. D is wrong because neither system is a federal standard. Both are product categories, and EHRs in particular are defined by ONC certification criteria rather than a single federal spec. Document management systems and electronic health records are two distinct categories that often get confused. Understanding what each one actually does, and why both still exist, is essential for navigating real-world health informatics. A document management system captures pages as images and organizes them with metadata like patient ID, document type, and date. The content stays locked inside the pixels, readable by humans but not queryable by machines. The EHR, by contrast, places every data point into a discrete structured field. Blood pressure goes into a blood pressure field. A diagnosis gets a coded entry. Because the data is structured, it can be queried, analyzed, and used for real-time decision support, capabilities a DMS simply cannot provide. The exam trap is treating these systems as interchangeable or as competitors. They are not. A hospital with a mature EHR still needs a document management system for signed consents, external referral letters, and historical paper charts that do not fit neatly into structured fields. When you see terms like scanned documents, images, or metadata on an exam stem, think document management system. When you see structured fields, decision support, or discrete data, think EHR. Both serve the modern hospital, just in fundamentally different ways. Question 15. A rural clinic that is 80 miles from the nearest specialty cardiology practice wants to reduce patient travel burden for follow-up visits. Which technology most directly addresses this concern? Your options are A patient portal for scheduling and secure messaging only. B, a clinical decision support module added to the primary care EHR. C, telemedicine visits that allow real-time specialist consultations by video. D, a document management system that scans past paper records. Don't overthink it. Which one feels right? The correct answer is C. Telemedicine visits that allow real-time specialist consultations by video. C is correct because telemedicine uses real-time audio and video technology to connect patients with clinicians who are not physically present. It is the main tool that eliminates the need to travel for routine specialty follow-up. A is wrong because a patient portal supports messaging and appointment management but does not replace the clinical encounter with a distant specialist. B is wrong because clinical decision support aids the local clinician's reasoning but does not provide specialist-to-patient interaction. D is wrong because document scanning preserves records but does not address the core travel burden for follow-up care. Telehealth and telemedicine are related but distinct concepts. Telehealth is the broad umbrella covering all healthcare delivery, education, and administration supported by technology across distance. Telemedicine is the narrower term referring specifically to clinical care delivered remotely. Telehealth operates through three distinct modes. Synchronous telehealth is real-time video between patient and clinician. Asynchronous, or stored and forward, sends images or data for later review. Remote patient monitoring continuously collects home data, like blood pressure or glucose, and transmits it to the care team. The fundamental value of telehealth is removing geography as a barrier. Rural patients hours from a specialist, elderly patients with mobility limits, and working adults who cannot afford half-day absences all benefit when the visit moves to them rather than requiring them to travel. Telehealth brings real benefits: broader access, less travel, and more frequent monitoring for chronic conditions. But drawbacks persist. Video cannot replicate every physical exam. Patients without reliable broadband are left behind. And reimbursement rules remain inconsistent across states and payers. Don't confuse telehealth with a patient portal. A portal supports messaging and scheduling, but telehealth actually delivers the clinical encounter across distance. That distinction is why telehealth, not a portal, is the answer whenever an exam STEM mentions reducing travel burden for specialty care. Question 16. A project manager is kicking off a new laboratory information system project and wants to follow a recognized framework that structures phases from planning through maintenance. Which framework is she applying? Your options are A. Master Patient Index Design, B. Clinical Pathway Standardization, C. Health Information Exchange Architecture, D. Systems Development Lifecycle. Got a guess? Lock it in. The correct answer is D. Systems Development Lifecycle. D is correct because the Systems Development Lifecycle provides a structured set of phases including planning, analysis, design, development, implementation, and maintenance. It is the framework used for information system projects in healthcare. A is wrong because the Master Patient Index is a data management tool. It is not a project framework. B is wrong because clinical pathways standardize care for specific conditions. They are clinical, not development frameworks. C is wrong because HIE architecture decisions come up during system selection, but are not a phase project framework themselves. Every information system project, whether building custom software or selecting a vendor product, needs a structured framework to guide it from first idea to eventual retirement. That framework is the Systems Development Lifecycle, or SDLC. The classic SDLC flows through 6 phases: planning, analysis, design, development or acquisition, implementation, and maintenance. Each phase produces specific deliverables that feed the next, and skipping or rushing early phases is the leading cause of project failure. The planning and analysis phases set the entire foundation. Teams that jump into coding or vendor selection without understanding users and operational constraints consistently produce systems that fail to deliver expected benefits. Requirements gathered from frontline workers, not just leadership, are essential. The critical exam distinction is that the SDLC is a framework, not a specific method. Waterfall, agile, iterative, and parallel development are all methods that operate inside this framework. The framework provides the phase structure. The chosen method determines how those phases are sequenced and controlled. Question 17. A software vendor proposes a development approach that completes requirements, analysis before design, then design before coding, then coding before testing, with no return to earlier phases. What is the main trade-off of this approach? Your options are A. It offers strict sequencing and documentation but limits user feedback during development. B. It delivers working prototypes every 2 weeks for user review. C. It overlaps design and coding, so both phases finish at the same time. D. It integrates testing at every stage to catch defects early. Which one is it? Pause the video if you need more time. The correct answer is A. It offers strict sequencing and documentation, but limits user feedback during development. A is correct because the waterfall method moves strictly from one phase to the next with no backtracking. It produces heavy documentation and enforces discipline, but keeps end users out of the picture until late, which is its main criticism. B is wrong because 2-week iterative deliverables describe agile development, not waterfall. C is wrong because overlapping design and coding describes the parallel method, where phases run concurrently to shorten timelines. D is wrong because testing integrated at every stage describes the V model, which pairs each development stage with a corresponding testing stage. The waterfall method is one of the oldest and most structured approaches to software development. Understanding why it was created and where it still fits helps you apply it correctly rather than dismiss it outright. Each phase completes fully before the next begins. Requirements are locked before design starts. Design is finished before coding begins, and testing only happens after all code is written. Documentation produced at each stage becomes the formal input to the next phase down. Managers, budget owners, and auditors all valued waterfall for the same reason. It made progress visible. Deliverables appeared at defined checkpoints, and every requirement could be traced through design, code, and test. That discipline was a natural fit for the engineering culture of the time. When requirements are stable and well understood, waterfall produces reliable, well-documented results, which is exactly why regulated industries like aerospace and medical devices still use it. The danger appears when requirements change mid-project or users cannot articulate their needs until they see a working system. Defects introduced early may not surface until testing, months after the mistake was made. The key insight is that no method is universally right or wrong. Waterfall remains the correct choice when requirements are locked. Traceability is mandatory, and the problem is well understood from the start. Where requirements evolve through use, iterative or agile approaches serve better. Question 18. A development team is pressured to deliver a new billing system in half the usual timeline. A senior architect suggests splitting the work so that some design, coding, and testing happen concurrently across sub-teams, with integration near the end. Which SDLC variation is being proposed? Your options are A. Waterfall method, B. Parallel method, C. Big Bang Go Live, D. V model. Take a second. Which answer would you pick? The correct answer is B. Parallel method. B is correct because the parallel method breaks a project into concurrent tracks so that design, coding, and testing happen in parallel on different components. It shortens timelines but introduces integration risk when the pieces come together. A is wrong because waterfall is strictly sequential and would not shorten timelines this way. C is wrong because Big Bang is a go-live strategy, not a development method. It refers to cutting over all users at once rather than phasing. D is wrong because the V model pairs testing activities with each development stage. It does not describe concurrent work streams. The parallel method is a structured approach to software development that tackles one of waterfall's biggest weaknesses, long total timelines. Instead of running every phase in sequence, teams work on separate modules at the same time. The project is broken into loosely coupled modules, each assigned to a dedicated sub-team. Those teams run design, coding, and testing in parallel. When the tracks finish, integration assembles the pieces into a working whole. The calendar time savings come from a simple principle. The project finishes when the longest track finishes, not when all track durations are added together. This compression only works when modules have well-defined interface contracts, so teams can develop independently without constant coordination. The gains are real but conditional. Shorter delivery windows and better use of specialized skills are genuine advantages. However, when modules are tightly coupled or interface assumptions conflict at integration, The time savings evaporate and new defects surface. A critical exam distinction. The parallel method is a development strategy, not a go-live strategy. Parallel testing, where an old and new system runs simultaneously during cutover, is a separate concept in the implementation phase. Reading the scenario carefully for where in the life cycle the action occurs resolves the ambiguity. Question 19. An implementation team wants a development method that pairs each development phase with a corresponding validation and testing phase, so that defects are caught closer to when they are introduced. Which method matches this description? Your options are A. Big Bang, B. Parallel method, C. Validation and verification model, D. Waterfall method. Before I reveal it, which one do you think is right? The correct answer is C. Validation and verification model. C is correct because the validation and verification model, known as the V model, explicitly matches each development stage with a testing stage. Requirements pair with acceptance testing, design pairs with integration testing, and coding pairs with unit testing. A is wrong because Big Bang is a go-live style, not a paired stage model. B is wrong because the parallel method emphasizes concurrent work streams, not stage-by-stage testing pairs. D is wrong because Waterfall places testing at the end as a single phase. It does not distribute testing across every development stage. The V model is a structured development approach that directly addresses one of Waterfall's biggest weaknesses, finding defects too late. Rather than treating testing as a final step, it pairs every development phase with a corresponding testing phase planned at the same time. The left arm of the V represents development activities moving downward from requirements through design to coding. The right arm represents testing activities moving upward. Each level on the left is directly paired with a level on the right. And crucially, the test plan for each pair is written when the development artifact is created, not after. The model distinguishes two distinct questions. Verification asks whether each phase's output correctly matches the previous phase's specification. Was it built right? Validation asks whether the final product actually meets original user needs. Was the right thing built? The V model makes both checks explicit at different levels. The V model excels in regulated environments like healthcare, aerospace, and defense, where traceability from requirements to test is mandatory. However, its rigidity is a real cost. Late changes force rework across multiple levels simultaneously, making it a poor match for projects with volatile or evolving requirements. When an exam stem describes matching each development phase with a corresponding testing phase, or mentions acceptance testing paired with requirements, the answer is the V model. It is the framework that makes testing a first-class activity at every level, not a final afterthought. Question 20. 6 months into a new electronic health record rollout, stakeholders keep requesting new features that were not in the original specifications. The project manager notices the go-live date slipping and the budget stretching. Which project management concept describes what is happening? Your options are A. Force majeure, B. Re-engineering, C. Change management, D. Scope creep. What's your answer? Commit to one before I continue. The correct answer is D. Scope creep. D is correct because scope creep is the gradual expansion of a project's scope through unapproved additions of new features or requirements after the baseline is set. Timeline slip and budget stretch are the signature signals. A is wrong because force majeure refers to contract clauses that excuse performance due to extraordinary events like natural disasters. It is not a scope issue. B is wrong because re-engineering is the redesign of workflows and processes, often tied to system implementation. It is a scope choice made up front, not creep. C is wrong because change management is the discipline of guiding people through change. It is the response to change, not the unplanned expansion of project scope. Scope creep is the gradual, uncontrolled expansion of a project's boundaries through incremental additions after the baseline has been set. Unlike legitimate scope change, scope creep accumulates informally, without deliberate review or approval. Scope pressure is nearly universal. Stakeholders discover new needs as the project unfolds. Fresh ideas surface during design, and executives see capabilities elsewhere and want the same. Each individual request seems small, but together they can consume double-digit percentages of the original budget. The mechanism that keeps projects honest is a formal change control process. Every proposed change must be documented, evaluated for its impact on scope, schedule, and budget, and approved by the right authority before it is incorporated into a revised baseline. Changes that don't meet the threshold get deferred, not silently absorbed. Scope creep is easy to confuse with related concepts. Legitimate scope change responds to external forces like new regulations. Re-engineering is intentional process redesign. Change management guides people through transitions. None of these are the same as informal, uncontrolled feature additions. The goal is never to eliminate change entirely. That's unrealistic. The goal is to ensure every change goes through a defined process. When additions bypass that process, you get the telltale symptoms: timeline slip and budget overrun. Question 21. A hospital is early in system selection and wants to gather general information from several vendors to understand what capabilities are available before committing to a formal procurement. Which document should the hospital issue first? Your options are: A. Request for information, which gathers general capability data from vendors. B. Request for proposal, which requires detailed, binding responses to specifications. C. Statement of work, which defines contracted deliverables after selection. D. Service level agreement, which sets performance metrics for a running system. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Request for information, which gathers general capability data from vendors. A is correct because a request for information is the exploratory tool used early in selection to learn about vendors and their capabilities. It is non-binding and lets the organization narrow the field before committing to a formal proposal round. B is wrong because a request for proposal comes later and demands detailed, priced, binding responses. It is used after the field has been narrowed. C is wrong because a statement of work is a contractual document defining deliverables after a vendor has been selected. It is not an information gathering tool. D is wrong because a service level agreement specifies performance thresholds for an already running system. It does not fit the pre-selection phase. Two procurement documents that look similar are actually used at different stages of the selection process and carry very different levels of commitment. Understanding the distinction prevents major planning errors. The process moves in stages. A request for information casts a wide net to learn what the market offers. A request for proposal targets serious candidates with detailed requirements. Contract negotiation closes with a single vendor. Picture a funnel. The information round might go out to 10 or more vendors. The proposal round focuses on 3 to 5. Demonstrations narrow it further, and contract negotiation closes with 1. Each step adds commitment from both sides. The binding nature is the critical exam signal. In an RFR, neither side commits. The vendor is not promising pricing and the buyer is not promising a purchase. In an RFP, vendor responses are binding, including pricing, timelines, and specific commitments. When an exam STEM describes early capability gathering before detailed specifications exist, the answer is the request for information. When it describes scored, binding responses against defined requirements, the answer is the request for proposal. Question 22. A chief information officer is choosing between buying an integrated suite from one vendor that covers most hospital functions or assembling specialty systems from different vendors for lab, pharmacy, and radiology. She chooses the single vendor suite. Which term describes her approach? Your options are A. Best of breed because each module was picked as leader in its category. B. Best of suite because suite purchasing is always faster than breed selection. C. Best of fit because a single vendor supplies most modules and integration is built in. D. Best of cost because single vendor contracts are always cheaper than multi-vendor. Which would you go with? Lock it in before the reveal. The correct answer is C. Best of fit because a single vendor supplies most modules and integration is built in. C is correct because best of fit describes buying a broad integrated suite from one vendor. Modules share architecture and data models, so interfaces and data flow are built in rather than constructed department by department. I is wrong because best of breed is the opposite strategy. It picks the strongest specialty system in each area from different vendors. The CIO explicitly rejected that mix. B is wrong because best of suite is not the standard industry term. The recognized pair is best of fit versus best of breed. D is wrong because best of cost is not a real procurement category, and single vendor suites are not automatically cheaper. Pricing varies widely by contract. When hospitals build their software portfolios, they face a fundamental choice between two procurement strategies. Understanding what separates them and when each makes sense is the core concept here. Best of fit means one vendor supplies most or all modules. EHR, pharmacy, lab, radiology, sharing the same data model throughout. Best of breed means selecting the strongest specialist system in each area, even when that means juggling multiple vendors. In a best of fit model, integration is built in. Modules share patient identifiers, medications, and results without custom work. In a best of breed model, each department gets a superior specialized tool, but the hospital must build and maintain interfaces connecting systems that were never designed to talk to each other. Best of fit wins on simplicity, fewer vendors, consistent user experience, and no custom interface burden. Best of breed wins on capability depth, but the hospital pays in interface development costs, multi-vendor management, and painful upgrade coordination when vendors change systems on incompatible timelines. On the exam, map the language precisely. A single vendor covering most modules signals best of fit. Specialty systems from different vendors connected through interface development signals best of breed. There is no best of suite or best of cost, only these two terms. Question 23. A software company has just finished internal development of a new coding system and wants to test it in a live hospital environment before general release. The company is choosing hospitals to act as initial real-world test sites. Which term describes these early hospital partners? Your options are A. Alpha sites, which are developer-only testing environments. B. Beta sites, which are external customer sites used for real-world testing before release. C. Parallel sites, which run old and new systems simultaneously for long-term comparison. D. Shadow sites, which run only for audit documentation. Don't overthink it. Which one feels right? The correct answer is B. Beta sites, which are external customer sites used for real-world testing before release. B is correct because beta sites are external customer organizations that test software in real-world conditions before the vendor releases it generally. Healthcare vendors partner with select hospitals as beta sites to catch issues that internal testing missed. A is wrong because alpha testing happens inside the vendor's own development environment before any outside hospital gets involved. It is not a customer site. C is wrong because parallel sites is not a standard term for this stage. Parallel testing is a technique within a single site where old and new systems run side by side during cutover. D is wrong because shadow sites is not a standard term in the system selection and implementation literature. Before any software reaches the general market, it passes through two distinct testing stages. Understanding who runs each stage and where it happens is the key to telling them apart. Alpha testing happens entirely inside the vendor's own facility using synthetic data and internal staff. Only after that phase does beta testing begin at real hospital sites, leading eventually to general release. In alpha, the vendor's own team exercises the software against controlled test scenarios to catch obvious defects. Beta sites then expose the software to real clinical environments, uncovering issues that synthetic data and internal labs simply cannot replicate. Real clinical environments generate complexity that internal testing cannot reproduce. Beta hospitals absorb early risk in exchange for benefits like reduced licensing fees or early feature access, and their feedback meaningfully matures the product. When a question stem describes external customer organizations running software before general release, that is beta testing. If the testing is inside the vendor's walls with no hospital involvement, that is alpha. Those two locations resolve any ambiguity. Question 24. A selection committee comparing 3 EHR vendors gives each vendor a score on 30 evaluation criteria. The committee weighs each criterion by importance to the organization and sums weighted scores to produce a final ranking. What is this evaluation tool called? Your options are A. Cost-benefit analysis, B. Gap analysis, C. Request for proposal scoring, D. Weighted decision matrix. Got a guess? Lock it in. The correct answer is D. Weighted decision matrix. D is correct because a weighted decision matrix assigns importance weights to evaluation criteria, scores each vendor against each criterion, and sums the weighted results to rank options. It is the standard quantitative comparison tool in system selection. A is wrong because cost-benefit analysis compares financial cost against expected benefit for a single option. It does not directly rank multiple vendors on 30 criteria. B is wrong because gap analysis identifies differences between current state and desired state. It is not a ranking tool for competing products. C is wrong because RFP scoring is a broader process that may include a weighted decision matrix as one technique, but the matrix is the specific named tool the committee is using. When selecting a health information system, decision makers need more than gut instinct. The weighted decision matrix is the structured quantitative tool that brings rigor to that process. The matrix places criteria in rows and candidate systems in columns. Each cell holds a score and each criterion carries a weight. Multiply scores by weights and sum across all criteria to get each vendor's final ranking. The critical discipline is setting weights before viewing vendor demonstrations. Calibrating weights afterward introduces bias toward whichever vendor presented most impressively, rather than whichever fits the organization's actual priorities. When committee members disagree, the matrix redirects the argument from which vendor feels better to which criteria should carry more weight. That structured conversation produces a final report executives can confidently sign off on. On the exam, distinguish the weighted decision matrix from similar tools. It is the specific instrument that quantitatively ranks multiple competing options using defined criteria, numerical scores, and calibrated weights. Nothing else plays exactly that role. Question 25. A hospital legal counsel is reviewing a contract with a cloud EHR vendor. Counsel asks to verify the contract clause that protects both parties from liability when performance becomes impossible due to events like earthquakes, hurricanes, or acts of war. Which clause is she checking? Your options are force majeure clause, B. Confidentiality clause. C. Termination for cause clause. D. Indemnification clause. Which one is it? Pause the video if you need more time. The correct answer is A. Force majeure clause. A is correct because a force majeure clause relieves parties of contractual obligations when extraordinary events outside their control make performance impossible. Natural disasters and acts of war are textbook triggers. B is wrong because a confidentiality clause governs handling of proprietary information. It does not address performance during disasters. C is wrong because termination for cause allows a party to end the contract when the other breaches material obligations. It is not an excuse for non-performance due to external events. D is wrong because indemnification allocates liability for claims brought by third parties. It does not cover impossibility from natural disasters. Force majeure is a contract provision that excuses parties from performing when extraordinary events outside their control make performance impossible. Understanding this clause is essential for anyone working with healthcare technology contracts. A typical force majeure clause lists specific qualifying events. These fall into broad categories: natural disasters, armed conflict, government mandates, and increasingly, pandemics and major cyber attacks. The clause spells out exactly which events qualify and what consequences follow. When a qualifying event occurs, the clause activates a structured set of remedies. Performance obligations may be suspended, timelines extended, or termination rights triggered if the disruption lasts too long. Critically, the clause does not apply to routine failures or risks the affected party could have anticipated and mitigated. A key exam skill is distinguishing force majeure from similar sounding provisions. Indemnification handles liability from third-party claims, not performance impossibility. Termination for cause requires one party to have breached. It demands fault. Force majeure is specifically reserved for extraordinary external events where no party is at fault. Courts interpret force majeure language narrowly, so the specific wording in each contract matters. If an event was foreseeable or could have been mitigated, the clause will not apply. Force majeure is a precise legal tool, not a general escape hatch for inconvenience. Question 26. Two go-live strategies are being compared for a system-wide EHR rollout across 12 hospital campuses. One method flips everyone over on the same day. The other moves campus by campus across 6 months. Which statement about relative risk is correct? Your options are: A. Both methods carry equal risk because risk depends only on training quality. B. The Big Bang method carries higher risk because a single failure affects all users at once. C. The phased method carries higher risk because it prolongs coexistence of old and new systems. D. Neither method is risky when adequate testing has been performed. Take a second. Which answer would you pick? The correct answer is B. The Big Bang method carries higher risk because a single failure affects all users at once. B is correct because Big Bang Go Live flips all users at once. So any system failure, training gap, or workflow error hits the entire organization simultaneously. That concentration of impact is why it is considered the riskier approach. A is wrong because risk depends on strategy choice as well as training. Equal risk claims ignore the structural difference between the approaches. C is wrong because prolonged coexistence adds complexity, but it also contains failures to one campus at a time. That containment is why phased is considered the lower risk option. D is wrong because testing reduces risk, but does not eliminate the structural difference in blast radius between the two strategies. When a health system deploys a new information system, one of the most consequential decisions is how to flip users from the old system to the new one. Two dominant strategies frame that choice: phased rollout and Big Bang. Phased go live moves users in waves, one campus or department at a time. so that failures at early sites are contained and corrected before the next wave cuts over. Big Bang flips every user simultaneously, concentrating all risk into a single moment. In a phased rollout, the organization absorbs one wave at a time, fixing problems before the next site goes live. In the Big Bang cutover, every campus, department, and user group moves together, which means any failure is instantly system-wide. The exam nuance is about where risk concentrates. Phased approaches spread failures across time and sites, making them the lower risk strategy overall. Big Bang eliminates the coexistence burden quickly, but any single failure hits all users at once. That concentration is why Big Bang is classified as the higher risk approach. Students sometimes assume phased projects feel harder to manage and therefore carry more risk. J'excuse, but the relevant dimension is blast radius, not complexity. When a STEM asks which strategy carries higher risk, Big Bang is the answer because failure impact is fully concentrated at the moment of cutover. Question 27. A project team is preparing for a new laboratory information system that must send H7 results messages to the hospital EHR. They want to confirm that messages cross correctly between systems before go live. Which type of testing specifically addresses this concern? Your options are A. Volume testing, B. Acceptance testing, C. Training testing, D. Interface testing. Before I reveal it, which one do you think is right? The correct answer is D. Interface testing. D is correct because interface testing verifies that data moves correctly between connected systems, including message structure, field mapping, and error handling. HL7 exchange between a lab system and an EHR is a classic interface testing scenario. A is wrong because volume testing checks how the system performs under heavy load. It does not focus on cross-system messaging correctness. B is wrong because acceptance testing is the final stage where end users confirm the system meets business requirements. It happens after interface issues are resolved. C is wrong because training testing refines training materials and trainer delivery. It does not test data exchange between applications. Interface testing is a distinct category that focuses on the boundary between separate systems rather than the internal behavior of any single one. Let's look at why this boundary matters so much in healthcare IT. Healthcare environments run dozens of systems that must exchange data continuously. An interface engine acts as the translator between them, converting messages from one system's format into another's. Every one of those translation points is a potential failure. Test cases send messages through the interface engine and verify that every required field lands in the correct place in the receiving system. Malformed messages should produce clear error logs rather than silent data loss, which is exactly what interface testing confirms. Interface testing covers 4 main scenario types: normal path traffic for typical messages, edge cases for unusual but valid data, error conditions for malformed messages, and load scenarios to confirm the interface holds up under peak volume. When an exam STEM mentions data moving between connected systems, HL7 messaging, or field mapping across applications, that signals interface testing. Volume testing is about load. Acceptance testing is about business requirements. Interface testing is specifically about what happens at the seam between systems. Question 20. A hospital rolling out a new nursing documentation system has limited vendor trainers but thousands of nurses to prepare. The training lead decides to train a small group of in-house super users who will then deliver training to their peers. Which training approach is being used? Your options are A. Train the trainer, B. Computer-based self-paced training, C. Vendor-only direct training, D. Unstructured on-the-job shadowing. What's your answer? Commit to one before I continue. The correct answer is A. Train the trainer. A is correct because train the trainer prepares a smaller group of internal super users in depth so they can deliver consistent training to larger groups. It scales training efficiently when vendor capacity is limited. B is wrong because computer-based self-paced training is a delivery method, not the model where super users teach peers. C is wrong because vendor-only training is exactly what Train the Trainer is designed to work around when vendor time is scarce. D is wrong because unstructured shadowing produces inconsistent learning and is not the model described in the scenario. When a new information system rolls out, training determines whether it actually succeeds. Train the Trainer is a specific, named model designed to solve a very common problem. There are never enough vendor trainers to reach everyone who needs to learn the system. The model works in 2 stages. First, vendor trainers intensively prepare a smaller group of internal super users over days or weeks. Then those super users turn around and deliver training to the much larger population of end users, multiplying the organization's training capacity through a cascade structure. This cascade structure is what defines Train the Trainer. A small cohort of super users absorbs deep expertise from the vendor, then fans out across the organization to train peers. Because super users already know the local workflows and the people they are teaching, the training is often more relevant and effective than generic vendor-delivered sessions. The model has real drawbacks if super users are chosen for convenience rather than capability. A super user needs domain expertise, genuine teaching ability, and enough protected time to complete the intensive training. Organizations that cut corners here see inconsistent, low-quality training ripple all the way down to end users. On an exam, Train the Trainer describes specifically this 2-stage cascade, not self-paced modules, not vendor-only delivery, and not informal on-the-job learning. When a STEM describes a small group receiving intensive training and then teaching their peers, that cascade structure is the signal that Train the Trainer is the correct answer. Question 20. During migration from a legacy registration system to a new EHR, the project team needs to move years of patient demographic, insurance, and encounter history into the new database with correct structure and consistent values. Which implementation activity is this? Your options are A. Interface testing, B. User interface design, C. Data conversion, D. Re-engineering. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Data conversion. C is correct because data conversion moves data from the legacy system into the new system structure, cleansing and reformatting along the way so the new system receives usable, consistent values. Long history migrations fall squarely in this activity. Is wrong because interface testing checks ongoing message exchange between connected systems. It is separate from bulk historical data migration. B is wrong because user interface design shapes screens and workflow presentation. It does not address historical data movement. D is wrong because re-engineering is process redesign around the new system. It accompanies but does not describe the act of moving data itself. Data conversion is the process of migrating historical data from a legacy system into a new information system, restructuring it to fit the new data model along the way. It is consistently one of the highest risk activities in any healthcare IT implementation. Healthcare organizations carry decades of critical records in their legacy systems. Leaving that history behind would force clinicians to reconstruct patient context on the fly. It's an unacceptable risk to patient safety and continuity of care. The conversion process moves through 5 distinct phases: mapping, extraction, transformation and cleansing, loading, and finally validation. Each phase has its own tools and quality checks, and cleansing often runs in parallel to resolve duplicates, missing values, and outdated codes before go live. The consequences of a failed conversion extend far beyond IT. Lost records leave patient histories incomplete. Scrambled fields can put the wrong medication on the wrong patient. And data that loads successfully but is unusable operationally creates its own category of harm. On the exam, distinguish data conversion from interface testing, which handles live ongoing message exchange, and from re-engineering, which concerns process redesign. Data conversion specifically means the structured, phased migration of historical data into a new system, called MATI, and in healthcare, it is rarely quick or simple. Question 30. An IT team wants to confirm that a new emergency department tracking system will hold up when all 50 staff terminals log in simultaneously at shift change and patient census spikes. Which type of testing best addresses this concern? Your options are A. Interface testing, B. Volume testing, C. Acceptance testing, D. Conversion testing. Which would you go with? Lock it in before the reveal. The correct answer is B. Volume testing. B is correct because volume testing evaluates how the system performs under heavy load conditions, simulating peak user counts and transaction volumes. Shift change with 50 simultaneous logins is a textbook volume test scenario. A is wrong because interface testing checks data exchange between connected systems. Simultaneous user load is not its focus. C is wrong because acceptance testing confirms the system meets business requirements. It occurs after performance testing and is not the load focus check. D is wrong because conversion testing validates that migrated data landed correctly in the new system. It does not exercise real-time load. Volume testing evaluates how an information system performs when pushed to its limits. It exists because systems that run smoothly at low load often degrade unpredictably when real-world peak conditions hit. Load is not a single number. It spans concurrent users, transaction rates, the volume of stored data, and how complex those queries are. All 4 dimensions stress the system in different ways. Specialized load generation tools spin up thousands of virtual users and drive them through realistic workflows. The system under test is then measured across response time, error rates, and resource utilization to identify where performance breaks down. Healthcare systems face predictable surge patterns, shift changes, emergency department peaks, billing cycles, and migration windows. Each produces a distinct load profile that volume testing must simulate and validate before go live. Fixing a slow query or a connection pool limit in testing costs a fraction of what it costs under fire. Volume testing gives teams the confidence that the system will hold up when clinicians and patients depend on it most. Question 31. A quality director wants a monthly report showing what happened last month, including number of readmissions, average length of stay, and top discharge diagnoses. She is not yet asking why or what might happen next. Which analytics category fits her request? Your options are A. Predictive analytics, B. Prescriptive analytics, C. Diagnostic analytics that identifies root causes, D. Descriptive analytics. Don't overthink it. Which one feels right? The correct answer is D. Descriptive analytics. D is correct because descriptive analytics summarizes what has already happened. Counts, averages, and top-end lists about past activity are the hallmark outputs. A is wrong because predictive analytics forecasts what is likely to happen next using models on historical data. The director did not ask for forecast. B is wrong because prescriptive analytics recommends actions based on predictions. That is 2 analytical steps ahead of what she wants. C is wrong because diagnostic analytics digs into why an outcome occurred. The director explicitly said she is not yet asking why. Descriptive analytics is the most foundational of the 4 analytics categories. Its core job is simple: tell us what happened. Before any organization can improve, it needs a shared, reliable picture of past performance. Typical outputs include counts, averages, ranges, distributions, and top end lists. Examples from healthcare include monthly readmission rates, average length of stay, top 10 discharge diagnoses, and patient distribution by insurance type. The four categories build on each other in increasing complexity. Diagnostic asks why something happened. Predictive asks what is likely to happen next. Prescriptive recommends specific actions. Each depends on the reliable foundation that descriptive analytics provides. Here is the key exam nuance. Visual sophistication does not determine the analytic category. A flashy interactive dashboard showing last month's readmission counts is still descriptive analytics, just as a polished scoreboard still only tells you what already happened. When an exam stem describes a report summarizing past activity, counts, averages, rates, with no prediction or recommendation involved, the answer is descriptive analytics, regardless of how advanced the dashboard looks. Question 32. A population health team builds a model that flags patients with the highest probability of hospital readmission within 30 days, and then recommends specific outreach actions for each flagged patient. Which two analytics types are combined in this workflow? Your options are A. Predictive for probability of readmission and prescriptive for recommended actions. B. Descriptive for probability and predictive for recommended actions. C. Diagnostic for probability and descriptive for recommended actions. D. Prescriptive for probability and predictive for recommended actions. Got a guess? Lock it in! The correct answer is A. Predictive for probability of readmission and prescriptive for recommended actions. A is correct because predictive analytics estimates the likelihood of a future event. Prescriptive analytics moves beyond the estimate to recommend specific actions. Flag plus action is exactly that pairing. B is wrong because descriptive analytics summarizes past activity and does not produce probabilities for future events. C is wrong because diagnostic analytics explains why something happened. Descriptive does not recommend actions. D is wrong because the labels are reversed. Probability is predictive and action recommendation is prescriptive, not the other way around. Two of the most powerful analytics categories build on everything that comes before them. Predictive analytics estimates the likelihood of a future event, while prescriptive analytics recommends a specific action to take based on that estimate. Think of these as a chain. Descriptive reporting tells you readmissions are high. Predictive modeling tells you which specific patients are likely to be readmitted. Prescriptive analytics closes the loop by telling your care team exactly what to do about each flagged patient. In practice, these two layers are chained together. The predictive model scores every discharged patient, and patients above a risk threshold are passed to the prescriptive engine. The prescriptive layer weighs available interventions, their expected effectiveness, and operational constraints like cost and capacity, then surfaces a ranked action recommendation. The exam nuance is recognizing the pairing pattern. When a STEM describes a risk score and a recommended intervention, both categories are present. The critical distinction is simple. Probability is predictive. Action recommendation is prescriptive, regardless of how the two are combined in any workflow. Question 33. A database administrator is documenting every data element in the hospital registration database, including each field's name, data type, allowed values, and description of what the field means. She plans to share this with analysts and developers. What is she producing? Your options are A. Data warehouse schema, B. Source of truth index, C. Data dictionary, D. Audit trail. Which one is it? Pause the video if you need more time. The correct answer is C. Data dictionary. C is correct because a data dictionary is the catalog of an information system's data elements. It records each field's name, type, allowed values, and meaning so that everyone who touches the data uses it consistently. A is wrong because a data warehouse schema describes how warehouse tables are structured for analysis. It typically sits on top of operational data definitions rather than replacing them. B is wrong because source of truth index is not a standard term in this context. D is wrong because an audit trail records what users did, not what the data elements mean. A data dictionary is the official catalog of every data element in an information system. It goes beyond database design by documenting not just structure, but meaning, giving every field a single, authoritative definition that all users share. Each entry in the dictionary captures both technical properties, like data type and length, and business meaning, like the precise definition of admit date. This prevents different teams from interpreting the same field in conflicting ways. A well-formed entry leaves no room for ambiguity. The technical side covers type and constraints. The business side pins down exactly what the field represents in operational reality. It's important to distinguish the data dictionary from related artifacts. A warehouse schema describes table structure for analysis. An audit tray records user actions on data. Only the data dictionary documents what each data element actually means. When a data dictionary exists, analysts produce consistent reports, developers map fields reliably, and new staff onboard faster. It is the single source of truth for what every piece of data in the system represents. Question 34. A clinical informaticist is selecting a comprehensive clinical terminology to encode findings, diagnoses, and procedures in the EHR with consistent meaning across specialties. Which terminology is most appropriate? Your options are A. ICD-10, which standardizes diagnosis and procedure coding for billing. B. Synomed CT, which provides a comprehensive clinical terminology. C. CPT, which codes physician services for claims. D. DRG, which groups hospital stays for inpatient reimbursement. Take a second. Which answer would you pick? The correct answer is B. Synomed CT, which provides a comprehensive clinical terminology. B is correct because synomed CT is the large, structured clinical terminology used to encode findings, diagnoses, and procedures consistently across specialties. It is the recommended vocabulary for semantic interoperability in EHRs. A is wrong because ICD-10 is a classification for billing and reporting, not a full clinical terminology. It lacks the granularity Synomed provides for bedside documentation. C is wrong because CPT codes describe physician services for reimbursement. It is narrower than Synomed and tied to billing rather than clinical meaning. D is wrong because diagnosis-related groups cluster hospital stays for payment. They are a grouping system, not a clinical vocabulary. Synomed CT is the most comprehensive clinical terminology in healthcare, covering hundreds of thousands of concepts across diseases, findings, procedures, body structures, and more. Unlike billing code sets, it exists to give clinical documentation a shared vocabulary with enough depth to capture real clinical meaning. Other terminologies each serve a narrow purpose. ICD-10 handles billing, link names, lab results, and RX norm covers drugs. Synomed CT is different. It covers the full clinical picture with the granularity needed for bedside documentation, which none of the others can match. Every Synomed CT concept has a unique identifier and relationships to parent and sibling concepts. A concept like acute bacterial sinusitis links upward to sinusitis and outward to causative organisms and anatomical structures. This hierarchy lets analytics roll up from specific to general and powers decision support rules built on concept classes. When two systems exchange clinical data, shared meaning requires a shared vocabulary. SNOMED CT fills that role for findings, diagnoses, and procedures. Meaningful use and ONC certification criteria embedded it as a required vocabulary for specific data elements, driving broad adoption across certified EHRs. When an exam STEM asks about a comprehensive clinical terminology for encoding findings, diagnoses, or procedures at the point of care, the answer is SNOMED CET, not ICD-10, not CPIRV, not LOINC. Those are narrower tools built for billing or specific data domains, not for capturing the full depth of clinical meaning. Question 35. A business intelligence team wants a database layer optimized for fast multi-dimensional analytic queries over large volumes of historical health data, supporting roll-ups by service line, provider, or time period. Which technology is most suited to this use? Your options are A. Master Patient Index, B. Online Transaction Processing, C. Row-level Transactional Database, D. Online Analytical Processing. Before I reveal it, which one do you think is right? The correct answer is D. Online Analytical Processing. D is correct because online analytical processing structures data in multi-dimensional cubes optimized for fast roll-ups and slicing across dimensions like service line, provider, and time. It is the standard BI backend for healthcare analytics. A is wrong because a master patient index resolves identity for patients. It is not an analytics engine. B is wrong because online transaction processing is tuned for high throughput, short writes and reads, like registration and order entry. It is the opposite design from analytical processing. C is wrong because row-level transactional databases serve operational needs. They do not optimize for cube-style multi-dimensional analysis. OLAP, Online Analytical Processing, IDRISA, is the engine behind business intelligence reporting. It's built specifically for fast, flexible analytic queries across large volumes of historical data, something ordinary transactional databases simply aren't designed to do. Operational systems use OLTP, optimized for inserting, updating, and retrieving individual records quickly. Analytical systems need the opposite, scanning millions of rows to compute total and trends. Because these goals conflict, most organizations run separate environments for each purpose. OLAP organizes data in cubes. Each axis represents a dimension: time, geography, service line, per year, and each cell holds a pre-computed measure like revenue or volume. Analysts can slice across a single dimension, drill down from year to month, or roll up from department to facility, all in seconds. In healthcare, OLAP powers dashboards for service line profitability, readmission tracking, utilization review, and quality reporting. These queries aggregate across millions of records but return in seconds because the cube pre-computes the answers along hierarchical dimensions. When an exam STEM describes fast multi-dimensional queries, roll up and drill down across dimensions, or a business intelligence backend, the answer is OLAP. That multi-dimensional aggregation pattern is what separates it from transactional OLTP systems. Question 36. A hospital discovers that a blood pressure value of 140/90 was entered as 490 because the keyboard sent extra keystrokes. The value in the record no longer matches what was actually measured. Which data quality characteristic has been violated? Your options are A. Data accuracy, B. Data timeliness, C. Data accessibility, D. Data granularity. What's your answer? Commit to one before I continue. The correct answer is A. Data accuracy. A is correct because data accuracy means the recorded value reflects the true state that was measured or observed. When an entry error changes the measured value, accuracy is broken at the source. B is wrong because timeliness asks whether data is available when needed. The error here is wrong value, not late value. C is wrong because accessibility addresses whether authorized users can reach the data. The error is in the value itself, not in reach. D is wrong because granularity addresses the level of detail captured. The error is in the value, not in the detail level. Data accuracy is the quality characteristic that asks one specific question. Does the stored value correctly reflect the true state it represents? It is the foundation of trustworthy health records. Accuracy failures come from multiple sources. A single decimal point typo during order entry can result in a tenfold dosing error. Each source demands its own specific prevention and detection strategy. Managing accuracy requires all three phases working together. Prevention stops errors at the source. Detection surfaces errors that slipped through. Correction amends the record while preserving the audit trail so the change itself is traceable. Accuracy is one dimension among several. Timeliness asks whether data is available when needed. Completeness asks whether all expected data exists. Accuracy asks only whether the recorded value matches the true state, and no single characteristic alone is sufficient. When clinicians, pharmacists, and billing teams act on a record, they assume the value is correct. Accuracy failures break that assumption and cascade into downstream errors that are costly to find and fix after the fact. Question 37. A clinical registry captures patient weights but stores them rounded to the nearest £10 for simplicity. A pediatric team complains that the data is not useful for their age group because small changes matter. Which data quality characteristic is insufficient for the pediatric use case? Your options are A. Data timeliness, B. Data accuracy, C. Data granularity, D. Data definition clarity. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Data granularity. C is correct because data granularity describes the level of detail captured. £10 rounding is too coarse for pediatric weight monitoring, so granularity is the specific characteristic that fails the clinical need. A is wrong because timeliness is about when data is captured, not how precisely. B is wrong because accuracy means the stored value reflects reality. A correctly recorded rounded value is accurate to its granularity. The failure is the granularity choice itself. D is wrong because data definition clarity is about shared meaning of the field. The field is clearly defined, the detail level is the problem. Data granularity is a foundational design concept in clinical informatics. Kisambuaksu. It describes how much detail a data element is built to capture. Understanding it helps you distinguish good data design from data that is simply too rough or unnecessarily complex for its intended use. Fine-grained data captures small units. A weight to the 10th of a kilogram, a timestamp to the second, a diagnosis coded to a specific SNOMED CT subtype, coarse-grained data groups values, a weight rounded to the nearest £10, a timestamp recorded only to the day, a diagnosis noted only at the body system level. The same conceptual data element, weight, time, or diagnosis, can be stored at very different levels of detail. Pediatric dosing may demand ounce-level precision, while an adult wellness report may work fine with coarser weight buckets. Neither is universally right. The use case determines the appropriate level. Too coarse and the data cannot support clinical decisions, like a registry that captures infant weights only to the nearest pound, making dosing calculations impossible. Too fine and you add storage cost, user burden, and privacy risk, since highly precise data can re-identify individuals in aggregate reports. Granularity is distinct from accuracy, timeliness, and completeness. A value can be perfectly correct and current, yet still fail its purpose because the data element was designed to capture too little detail. When an exam stem describes data that is right, but not detailed enough for the task, that is a granularity problem. Question 38. A lab result posts to the EHR 3 days after the specimen was drawn because of a manual batch upload process. Clinicians say the result is no longer useful for care decisions by the time they see it. Which data quality characteristic is most directly at issue? Your options are A. Data accuracy, B. Data timeliness, C. Data granularity, D. Data comprehensiveness. Which would you go with? Lock it in before the reveal. The correct answer is B. Data timeliness. B is correct because data timeliness addresses whether data is available when it is needed for decision making. A 3-day lab makes the result too late to drive care, which is a timeliness failure. A is wrong because the value itself may be accurate. The problem is how long it took to reach the clinician. C is wrong because granularity is about detail level. A delayed result can still be detailed. D is wrong because comprehensiveness covers whether the record contains everything it should. The record has the result, it just arrives late. Data timeliness is a distinct data quality dimension. It describes whether data is available when it is needed, not whether it is correct or complete. Understanding this dimension requires knowing where it fits among other quality characteristics and how delays actually happen. Accuracy asks whether a value is correct. Completeness asks whether all expected data is present. Timeliness asks a separate question entirely: did the data arrive in time to be used? A perfectly accurate lab result that posts 3 days late still fails the timeliness standard. Timeliness depends on every link in the pipeline from data creation to data availability. Source systems must capture events promptly. Interfaces must transmit without queuing delays. And downstream systems must process and surface data quickly. Each stage adds latency, and the total determines what the end user actually sees. Failures can occur at any stage. Batch processing can hold data for hours or days. Interface queues can stall under load. Manual documentation lags the underlying event. System outages pause the entire pipeline. Each failure mode has specific monitoring and mitigation strategies, including service-level agreements. When an exam stem describes a correctly documented value that arrives too late to influence a clinical decision, the concept being tested is timeliness, not accuracy, not completeness. Recognizing that distinction is the core exam skill for this quality dimension. Question 39. A HIM quantitative reviewer is checking whether every admission has a signed history and physical, a discharge summary, and physician progress notes for every day of stay. Which data quality characteristic is the review evaluating? Your options are A. Data consistency, B. Data currency, C. Data accuracy, D. Data comprehensiveness. Don't overthink it. Which one feels right? The correct answer is D. Data comprehensiveness. D is correct because comprehensiveness asks whether the record contains all elements that should be present for a complete picture. The HIM reviewer is literally checking for presence of required document types across the stay. A is wrong because consistency asks whether the same data element is recorded the same way across time and systems. The reviewer is not comparing duplicates. B is wrong because currency is about whether data is up to date. Presence of all expected documents is separate. C is wrong because accuracy addresses whether individual values are correct, not whether all documents exist. Comprehensiveness is the data quality characteristic that asks one focused question: does this record contain everything it should? It's about presence, whether all expected documentation exists for a given encounter. It's easy to confuse comprehensiveness with related concepts. Accuracy asks if values are correct. Timeliness asks when data arrives. Granularity asks how detailed it is. Comprehensiveness asks only whether everything that should be there is there, a complete set, not a correct one. In quantitative review, a HIM professional works through each discharge record and verifies that required documents are present. A history and physical, daily progress notes, operative reports, discharge summary, and signed consents are each checked. Any missing document triggers a deficiency notice routed to the responsible provider for correction. What counts as a comprehensive record isn't universal. Requirements depend on the encounter type, the services rendered, and organizational policy aligned with regulatory and accreditation standards. A surgical inpatient case carries far more documentation requirements than a routine outpatient visit. When an exam stem mentions quantitative review, required documentation, or complete record, that's comprehensiveness. A record can be accurate and timely, yet still fail comprehensiveness if a single expected document is missing. Question 40. A Chief Medical Information Officer wants to distinguish data integrity from data quality when briefing the board. Which statement correctly captures the difference? Your options are A. Data integrity means data has not been altered or lost in storage or transit. Data quality means data meets defined quality dimensions like accuracy and completeness. B. Data integrity and data quality are interchangeable terms with identical meaning. C. Data integrity applies only to paper records. Data quality applies only to electronic records. D. Data integrity is a federal requirement. Data quality is optional. Got a guess? Lock it in. The correct answer is A. Data integrity means data has not been altered or lost in storage or transit. Data quality means data meets defined quality dimensions like accuracy and completeness. A is correct because data integrity addresses whether data has been preserved unchanged through its life cycle, including storage, processing, and transmission. Data quality is the broader concept covering accuracy, completeness, consistency, timeliness, and other quality dimensions. B is wrong because the two terms overlap but are not interchangeable. Integrity is one foundation for quality, not the whole picture. C is wrong because both concepts apply to any record format, paper or electronic. D is wrong because both are expected in healthcare operations. Neither is optional when patient care and billing depend on the data. Data integrity and data quality both ask whether data can be trusted, but they operate at very different scopes. Understanding the distinction is essential for anyone managing health information. Data integrity asks one specific question: has the data been altered or lost since it was correctly captured? Controls like cryptographic hashes, audit logging, and access restrictions are designed to answer exactly that. Data quality is the broader framework. The HIPAA model identifies dimensions like accuracy, completeness, timeliness, and currency, each measuring a different aspect of fitness for use. Integrity is one foundation within that larger structure, not a substitute for it. A record with perfect integrity can still fail quality standards. It may have been captured incorrectly, be missing fields, or lack the granularity needed for clinical decisions. Integrity is necessary but not sufficient for data quality. On the exam, watch for signal words. Questions about alteration, corruption, or loss in storage and transit test integrity. Questions about accuracy, completeness, or multiple quality dimensions test the broader concept of data quality. Question 41. A security awareness trainer is explaining the difference between a virus and a worm to new hospital IT staff. Which statement correctly distinguishes the two? Your options are A. Viruses replicate independently across networks. Worms require a host file to spread. B. Viruses and worms are synonyms for the same malware type. C. Viruses require a host file and user action to spread. Worms self-replicate across networks without user action. D. Neither viruses nor worms can spread through email attachments. Which one is it? Pause the video if you need more time. The correct answer is C. Viruses require a host file and user action to spread. Worms self-replicate across networks without user action. C is correct because a virus attaches to a host file and requires the user to open or run the file to activate and spread. A worm self-replicates and propagates across networks on its own without user action. That self-propagation is what makes worms especially dangerous on hospital networks. A is wrong because the labels are reversed. Viruses need hosts and user action. Worms self-propagate. B is wrong because viruses and worms are distinct categories of malware, even though both replicate in a broad sense. D is wrong because both viruses and worms have been delivered through email attachments historically. Email is a common vector. Two of the most common malware categories, viruses and worms, are often confused, but they operate through fundamentally different mechanisms. Understanding that difference is essential for choosing the right defenses. A virus cannot run on its own. It embeds itself in a host file, an executable, document, or script, and waits. Only when a user opens or runs that file does the virus activate and begin spreading to other files. The core contrast is this. A virus travels inside files and needs a human to pull the trigger, while a worm moves across networks on its own, exploiting unpatched vulnerabilities to jump from machine to machine automatically. No user involvement required. Because the threats spread differently, the defenses emphasize different layers. Stopping viruses leans on user behavior and email controls. Stopping worms depends on keeping systems patched. Segmenting networks and using intrusion detection to catch lateral movement early. When an exam question describes malware that spreads without any user interaction, think worm. When it requires someone to open a file first, think virus. That single distinction resolves most questions on this topic. Question 42. A staff member downloads what appears to be a free calendar utility. After installation, the program secretly opens a backdoor that lets an attacker control the workstation. Which malware type does this describe? Your options are A. Virus because it attached to a host file. B. Trojan because it disguises itself as legitimate software to trick the user. C. Worm because it self-replicates across the network. D. Bot because it joins a coordinated group of infected devices. Take a second. Which answer would you pick? The correct answer is B. Trojan because it disguises itself as legitimate software to trick the user. B is correct because a Trojan presents itself as legitimate software, so the user willingly installs it, then carries out malicious actions once running. The disguise calendar tool that opens a backdoor is the textbook Trojan pattern. A is wrong because no virus-style host file attachment is described. The calendar app itself is the malicious payload. C is wrong because self-replication across the network is the signature of a worm, which is not what this scenario shows. D is wrong because bots turn infected devices into members of a controllable network. The scenario stops at backdoor access, not botnet membership. A Trojan is malware that disguises itself as legitimate software, tricking the user into installing it voluntarily. The name comes from the Greek myth of the wooden horse, a gift that concealed an attack force inside. Just as the Trojans wield the horse inside their own walls, the user brings the malicious payload past every technical defense by choosing to install it themselves. The disguise bypasses the human trust layer, the one defense no firewall can patch. Trojans reach victims through fake download sites, malicious email attachments, bundled installers, and even compromised legitimate vendors. Once installed, a single Trojan can open a backdoor, steal credentials, log keystrokes, encrypt files, or enlist the machine in a botnet, sometimes all at once. The defining Trojan feature is the disguise combined with user-initiated installation. A virus requires a host file to attach to. A worm spreads automatically without any user action. Only the Trojan relies on social engineering to deliver its payload. Trojan awareness training focuses on verifying software sources and questioning anything too good to be true. If the attack depends on convincing a user to install something, the disguise is the defining feature, and that is the Trojan. Question 43. A hospital network is hit with traffic that floods its patient portal from thousands of infected devices worldwide, all coordinated through a command and control server. Which malware concept is at work? Your options are A single virus executing on many machines independently. B, a Trojan that disguised itself at install time. C, a hot site failover triggered by an attack. D, a botnet made up of bot-infected devices under external control. Before I reveal it, which one do you think is right? The correct answer is D, a botnet made up of bot-infected devices under external control. D is correct because a botnet is a network of machines infected by bot malware and coordinated by a command and control server. Distributed denial of service attacks against a portal are one of the main uses of a botnet. A is wrong because independent virus execution does not coordinate thousands of machines against a single target at the same moment. B is wrong because Trojan describes the install mechanism. The coordinated flood behavior is botnet behavior. C is wrong because a hot site is a disaster recovery facility, not a type of malware or attack. A botnet is a network of attacker-controlled machines working in coordination. Understanding how botnets are structured and what makes them dangerous helps you recognize them on the exam and in the real world. The attacker issues commands to a command and control server, which distributes those instructions to thousands of infected devices. The bots run silently in the background. The victim rarely knows anything is wrong. A single botnet can include hundreds of thousands of devices spanning workstations, home routers, and Internet of Things hardware. That scale is what makes botnets so effective. Attack traffic comes from so many different source addresses that blocking individual ones is nearly impossible. Botnets are used for distributed denial of service attacks, mass spam, credential stuffing against websites, and quietly mining cryptocurrency on infected machines. Healthcare organizations have been targeted by all of these. The defining feature of a botnet is coordination. Many infected devices controlled through a central server. A single isolated infection is a different malware problem. When the scenario describes traffic from thousands of devices under external control, that is a botnet. Question 44. A hospital CISO wants to strengthen authentication beyond passwords alone for remote EHR access. She deploys small physical devices that generate a time-based code that clinicians must enter along with their password. What are these devices called? Your options are A. Security tokens used as a second authentication factor. B. Capture challenges that distinguish humans from bots. C. Audit trails that record user actions. D. Single sign-on appliances that reduce password count. What's your answer? Commit to one before I continue. The correct answer is A. Security tokens used as a second authentication factor. A is correct because security tokens generate time-based one-time codes that combine with a password to form two-factor authentication. Hospitals use them to harden remote EHR access. B is wrong because capture is used on web forms to distinguish humans from automated bots. It is not a second authentication factor for a clinician login. C is wrong because audit trails monitor activity after the fact. They do not authenticate users at the front door. D is wrong because single sign-on lets a user authenticate once and access multiple systems. It reduces password count but does not itself add a second factor. Multi-factor authentication strengthens login security by requiring more than one piece of evidence to prove your identity. The classic framework combines three distinct categories of proof. The three factors are something you know, like a password, something you have, like a security token, and something you are, like a fingerprint. Requiring any two of these makes an attacker's job dramatically harder because stealing a password alone no longer grants access. Security tokens generate short-lived, time-based one-time codes that expire within seconds or minutes. Even if an attacker captures a code or steals a password, neither piece alone is sufficient to complete login. Passwords have proven unreliable as the sole authentication factor because users reuse them, pick weak ones, and surrender them to phishing. Massive data breaches publish millions of working credentials that attackers test elsewhere. Adding a second factor breaks this attack model entirely. Security tokens are specifically a second authentication factor in the something you have category. They are distinct from captcha, which detects bots, single sign-on, which manages sessions, and audit trails, which log actions after access is granted. Question 45. A privacy officer is investigating whether an employee accessed the record of a celebrity patient without a care-related reason. She pulls a log that shows every user who touched that chart, the time of access, and what they viewed. Which HIPAA security rule safeguard produced this log? Your options are A. Access control safeguard, B. Audit control safeguard, C. Encryption safeguard, D. Workforce clearance procedure. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is B. Audit control safeguard. B is correct because audit controls are the technical safeguard that records user activity on systems containing EPHI. Audit trails answer after-the-fact questions about who accessed what and when, which is exactly what the privacy officer needed. A is wrong because access controls decide who is allowed in at the moment of login. They do not produce a retrospective record of actions. C is wrong because encryption protects data from unauthorized reading during storage or transit. It does not generate a user activity log. D is wrong because workforce clearance is about verifying role-based access before granting it. It is upstream of activity logging. Audit controls are a required safeguard under the HIPAA security rule, designed to record what authenticated users actually do on systems containing electronic protected health information. Unlike access controls that prevent unauthorized actions, audit controls detect and deter them by creating a permanent record. Each log entry typically captures the user's identity, the timestamp and originating device, the specific action taken, the record affected, and whether the action succeeded. Together, these fields answer retrospective questions that no other safeguard can answer. It is important to distinguish audit controls from related safeguards. Access controls, authentication, and encryption all act before or during access. Audit controls operate after the fact, making them primarily detective and deterrent rather than preventive controls. Audit logs support a range of real-world needs, from investigating a staff member who viewed a co-worker's chart without authorization, to producing records during litigation or a regulatory audit. Effectiveness depends on logs that are complete, tamper-resistant, and retained long enough to be useful. On the exam, any STEM describing a retrospective review of who accessed what and when is pointing at audit controls. Logs that are captured but never reviewed catch nothing. So both capture and active review are essential to making the safeguard work. Question 46. A community health nurse notices that a patient did not understand the discharge instructions and took medication on the wrong schedule. The patient said the printed sheet used words she did not recognize. Which concept describes the patient's challenge? Your options are A. Digital divide limiting portal access, B. Jargon being used intentionally by the nurse. C. Low health literacy that limits comprehension of health information. D. A HIPAA privacy rule barrier to sharing information. Which would you go with? Lock it in before the reveal. The correct answer is C. Low health literacy that limits comprehension of health information. C is correct because health literacy is the ability to obtain, process, and understand health information to make appropriate decisions. When printed instructions fail to land because the words are unfamiliar, the core issue is health literacy. A is wrong because the digital divide is about unequal access to digital tools and internet. The scenario uses a printed sheet. B is wrong because jargon is part of the problem but is a feature of the material rather than the patient's capacity. The concept describing the patient's challenge is health literacy. D is wrong because HIPAA is about privacy and security of information, not whether the patient can understand what is shared with her. Health literacy is about far more than reading ability. It encompasses a person's capacity to obtain, process, understand, and act on health information, and it sits at the intersection of patient characteristics and provider communication choices. True health literacy requires numeracy, listening, speaking, and cultural fluency, not just the ability to read. General literacy is only one contributing factor, which is why even well-educated patients can struggle when facing unfamiliar medical vocabulary under the stress of illness. About 1 in 3 American adults has limited health literacy. Contributing factors include age, primary language, cognitive ability, and even the emotional stress of being sick. The downstream consequences are serious: medication errors, poor disease management, higher emergency department use, and greater healthcare costs. Clinicians play a direct role in bridging health literacy gaps, using plain language instead of jargon, asking patients to repeat instructions back in their own words, and providing visuals or simplified written materials are the core evidence-based strategies. Remember, health literacy is a patient-side characteristic, but jargon is a provider-side behavior that actively makes it worse. Eliminating unnecessary clinical language, like saying high blood pressure instead of hypertension, is one of the most concrete steps a clinician can take. Question 47. A rural clinic rolls out a patient portal but finds that many elderly patients cannot use it because they do not have home broadband or the digital skills to log in. Which concept best describes this barrier? Your options are A. The digital divide, which reflects unequal access to technology and skills. B. The health disparity rule, which federally caps technology rollout. C. The Ask Me 3 initiative, which requires portal demos at every visit. D. Tethered portal syndrome, which is a technical integration issue. Don't overthink it. Which one feels right? The correct answer is A. The digital divide, which reflects unequal access to technology and skills. A is correct because the digital divide describes the gap in access to digital technology and the skills to use it. Elderly rural patients without broadband or digital confidence are the classic case. B is wrong because no federal health disparity rule caps technology rollout. The phrase is not a real regulation. C is wrong because Ask Me 3 is a patient communication tool focused on 3 key questions, not a portal mandate. D is wrong because tethered portal syndrome is not a real term. Tethered describes a type of PHR, not a disorder. The digital divide describes unequal access to digital technology and the skills needed to use it effectively. In healthcare, this divide has real consequences because portals, telehealth, and remote monitoring all depend on patients being able to connect. The divide is shaped by several overlapping factors. Rural communities often lack broadband infrastructure. Low-income households may not afford devices or internet. Older adults, patients with disabilities, and non-English speakers each face their own distinct barriers. When patients can't access these tools, they miss lab results, skip follow-up visits, and lose out on chronic disease management programs. Technology designed to improve access ends up deepening the very disparities it was meant to close. No single fix is enough. Expanding broadband, lending devices, building digital skills, and designing inclusive platforms must work together to incrementally reduce the gap for vulnerable populations. Remember, the digital divide is specifically about access to technology and the skills to use it, distinct from health literacy, which is about understanding health information regardless of how it's delivered. Both can affect the same patient, but they are separate problems requiring separate solutions. Question 48. A hospital launches an initiative to help patients ask their clinicians 3 specific questions at every encounter. What is my main problem? What do I need to do? And why is it important? Which recognized initiative is being adopted? Your options are A. Healthy People 2020, B. Meaningful Use Stage 3, C. National Patient Safety Goal 3, D. Ask Me 3. Got a guess? Lock it in. The correct answer is D. Ask Me 3. D is correct because Ask Me 3 is the Institute for Healthcare Improvement program that encourages patients to ask 3 specific questions at every visit. It is one of the main tools promoted to address low health literacy. A is wrong because Healthy People 2020 is a broad set of national public health objectives, not a 3-question patient tool. B is wrong because Meaningful Use Stage 3 set EHR certification and use criteria for providers, unrelated to patient questioning. C is wrong because National Patient Safety Goal 3 is a Joint Commission safety goal, not a health literacy program. Ask Me 3 is a structured patient education initiative developed by the Institute for Healthcare Improvement and the National Patient Safety Foundation. It gives patients a reliable framework for every healthcare encounter, regardless of setting or complexity. The 3 questions are intentionally simple. What is my main problem? What do I need to do? And why is it important? This structure works across any encounter type and gives patients an anchor even when visits are rushed or information is unfamiliar. Organizations embed the 3 prompts at multiple touchpoints. Waiting room posters, check-in materials, and discharge summaries all reinforce the pattern. Clinicians close each visit by confirming every question has been addressed, making the habit mutual. Research consistently shows patients misremember diagnoses and miss key instructions. Ask Me 3 breaks the silence. Patients fear looking uninformed, and the prompts signal that questions are welcome. Clinicians naturally shift toward plain language and teach back, benefiting patients at every literacy level. On the exam, recognize Ask Me 3 by its exact 3-question structure and its EHR origin. It is distinct from teach-back methods, general communication strategies, and healthy people initiatives. The specific framework is what identifies it. Question 49. A patient's primary care group offers a personal health record that is linked to the group's EHR so that lab results, medications, and visit summaries flow automatically into the patient's view. Which type of PHR is this? Your options are A. An untethered PHR that stores only data the patient manually enters. B. A tethered PHR connected to a specific provider's EHR. C. A covered entity PHR that is governed directly by HIPAA in all cases. D. A shadow PHR used only for marketing analytics. Which one is it? Pause the video if you need more time. The correct answer is B. A tethered PHR connected to a specific provider's EHR. B is correct because a tethered PHR is linked to a specific provider's EHR, so clinical data flows into the patient's view automatically. Primary care group portals that pull from the EHR are the most common example. A is wrong because untethered PHRs are standalone and rely on the patient to enter data manually. They are not linked to a provider's EHR. C is wrong because PHRs maintained by consumers or third-party vendors may fall outside direct HIPAA coverage even when they contain clinical data. The label does not automatically apply. D is wrong because shadow PHR is not a recognized category in consumer informatics. Personal health records are health information tools maintained for or by the patient, distinct from the provider-owned electronic health record. Understanding how they're structured helps clarify who owns the data and where it lives. The electronic health record belongs to the provider. A patient portal is the provider's window into that record. A personal health record, by contrast, is oriented around the patient as the primary user and steward. Tethered personal health records are linked to a specific provider's system. Lab results, medications, and visit summaries flow in automatically. Untethered records are standalone tools the patient populates manually or by importing from various sources, giving portability across any number of providers. The exam often tests whether you can distinguish tethered from untethered and whether you know that HIPAA protects a tethered PHR maintained by a covered entity but may not cover a third-party or consumer-maintained record. Patients with chronic conditions often benefit most from personal health records, and some use both types together. Pulling tethered data from multiple providers into a single untethered aggregator for a complete picture of their health. Question 50. A solo physician practice is preparing for its first year under a CMS program that evaluates provider performance on quality, improvement activities, promoting interoperability, and cost. Which program is being described? Your options are A. The Healthy People 2020 Initiative, B. The HIPAA Security Rule Audit Program, C. The Merit-Based Incentive Payment System, D. The High-Tech Certification Program. Take a second. Which answer would you pick? The correct answer is C. The Merit-Based Incentive Payment System. C is correct because the Merit-Based Incentive Payment System evaluates eligible clinicians on 4 categories: quality, improvement activities, promoting interoperability, and cost. Those are the exact 4 categories CMS uses in MIPS. A is wrong because Healthy People 2020 is a national population health objectives campaign, not a reimbursement program for clinicians. B is wrong because HIPAA security rule audits verify compliance with security safeguards. They do not evaluate clinical quality performance. D is wrong because high-tech drove EHR adoption through meaningful use incentives. MIPS replaced that specific payment program under MACRA. MIPS, the Merit-Based Incentive Payment System, is how Medicare links clinician reimbursement to performance rather than pure volume. It was created under MACRA in 2017, replacing the earlier Sustainable Growth Rate Formula and the Meaningful Use Program that High-Tech established in 2009. MIPS evaluates clinicians across exactly 4 performance categories. Quality and cost anchor the clinical and financial dimensions, while improvement activities credit practice-level work, and promoting interoperability, the successor to meaningful use, focuses on how effectively clinicians use electronic health records. Each category produces a score that rolls up into a composite. CMS compares that composite to an annual performance threshold. Clinicians above the threshold earn positive payment adjustments. Those below face negative ones. Exceptional performers can qualify for additional bonuses. The adjustment takes effect 2 years after the performance year. A key exam distinction: High-Tech created meaningful use to drive EHR adoption. MACRA replaced it with MIPS. HIPAA audits are separate regulatory compliance checks with no connection to clinician reimbursement. Recognizing these boundaries prevents the most common substitution errors on exam stems. MIP does not eliminate fee-for-service, but it inserts a performance lens into traditional Medicare payment, understanding its four categories. And what programs it replaced is what distinguishes it from unrelated policies on the exam.
You have reached the end of our first question set. For the free complete exam preparation, visit our website link in the description, where you find thousands more practice questions and comprehensive study guides. Thanks for studying with us today. See you in the next video.